No,
Which one?
yeah, but
Oh,
they've
sorry,
all
sorry,
seen
sorry.
me before, so you don't need to
Oh,
introduce me again.
yes. Sorry, I missed you there.
Doesn't matter.
All right, so we have the next topic, which is VAB, again, EVAB, extended VAB, and VAE, utilizing technology in appropriate clinical context. I
Yeah.
think that's exactly what we've been talking.
And honestly, this is just to pester you, I guess,
Dr.
right?
Ritseman is the breast and interventional radiologist, group leader of breast imaging from Netherlands. And I hope that he has some more points to prove that I should be accepting VABs and VAEs more often. Thank you.
It is what it is, right? You can't keep the future at bay. At the same time, biopsies in clinical context, honestly, I'm not going to tell you anything that you haven't heard today before. Really nothing. But I would like to make a few points. Most of what we do is diagnosis, right? Really diagnose. And in diagnosis, we try to apply Barrett's assessment categories to images. And subsequently, we get ourselves to a biopsy indication. And the indication for tissue sampling usually are these, right? We have an image, it's not Barrett 0, 1, or 2. Then we might argue about 3. Honestly, I dislike sending patients away and then asking them to come back for 2 years. So very often I still put a needle in. But in these cases, you shouldn't, right? And the more experience you get, the more things you get to call Barrett's 2 that otherwise other people might actually have called Barrett's 3 or Barrett's 4. But other than that, we like needles. Right? For me, the indications for tissue sampling are actually these. These are different ones from the ones I just gave. One of the major things is, okay, there's a lesion. I'm quite confident that this is benign. I will tell my patients, what you have is a fibroadenoma, but I'd like to prove it. Right? That makes me easier, it makes you easier, and I think after a while everyone will be more happy if we just do this, despite the 5 minutes of pain that you will have to sustain for this. Then there is a large group here where, well, whatever the pathologist is going to tell me, the patient has breast cancer, right? I know it very often before I walk into the ultrasound room because I saw it on the memo. And if not, by putting the ultrasound probe on the lesion, I sort of know where the story is going. So my request in a biopsy result like that is also not malignant question mark, but receptus question mark, right? It's a very different question to the pathologist. With that question, he also understands that anything else that is not benign or not malignant will lead to rebiopsy. Then we have the extensive assessment, right? And then there's a very small category in the middle that there is a lesion and I've actually no clue. It does exist, right? This is our classic Barrett's 4 situation. But it is actually a minority of the biopsies that we do. Just to prove the point, what is this? Thank you. These ones? Now it might be, this is the tricky part, right? Here I'm not entirely sure. They're both fibroadenomas, actually. This one? Malignant. Anyone who doubts that this is cancer? Okay, so very often you know what you're looking at, and then you obviously have your sampling needles. And we have been talking about vacuum-assisted biopsy all the time, but for all of these lesions, core would do, right? Just as simple as that. If you have to choose a biopsy technique, you can discuss about the accuracy of biopsy techniques. And the nice thing is, if you look into your literature, the sensitivity and specificity of core and vacuum are exactly the same, which is a bit of a tricky thing, right? Why would you use vacuum if it's actually the same sensitivity specificity as core? Trouble is obviously that here we already have selected our patients, right? So the vacuum population is a quite different one than the core needle biopsy population. Overall, you can delve into the studies on VAB. There's quite a lot of them. Specificity almost 100%, sensitivity roughly 95%. Sometimes we miss target and we still don't take enough tissue. But choosing a needle comes down to this, right? The bigger the lesion, the smaller the needle you can use. Which means the smaller the lesion, the bigger your needle will become. So it's sort of a counterintuitive thing, but really the only rationale about taking a bigger needle is because you're looking at a very small lesion. That is very difficult to sample, both for us, but also for the pathologist to interpret well. So he needs more tissue to actually get a good diagnosis. So vacuum is for the small or very diffuse lesions mostly, and potentially, we'll come to that, to remove lesions, some other ones in a while. Obviously, a couple of calcifications would be, well, how would you biopsy this? Stereo, right? And stereo is vacuum because these are small and diffuse lesions, right? Difficult to target well. If you take the calcification out, you have no clue whether you actually have the lesion because the calcification itself is not the lesion, right? It is the cells that surround it. That might be the issue. So calcification is stereo, and the nice thing about stereo and vacuum is that you have a direct control. Right? So you can prove that what you targeted is there. That doesn't always hold true for other biopsy techniques. I mean, some of these calcifications are actually well visible under ultrasound. And here you could biopsy the calcifications with a core needle, and you might actually have a very small sample that shows a calcification, but that simply doesn't yield enough tissue. I actually prefer biopsy under ultrasound over biopsy under mammo all the time, right? It is quicker, it's usually nicer for the patient, right? Being compressed in a mammography machine for 3/4 of an hour is just no fun. But if the lesion looks like this, vacuum actually might be quite helpful and can actually be done very well under ultrasound. Obviously, we have been talking a lot about this. MR has a very high sensitivity, is a very easy screening tool, but also means that you will have to find your lesions back. Roughly 60% is easily traceable on ultrasound and can be biopsied with core, but not all of your lesions, right? This is the nice overall meta-analysis on it, 60%. Obviously more of the malignant than of the benign lesions, but still not all, which means somehow that you need to have access to MR-guided biopsy. A quite straightforward approach, right? There's many different things, and for these kind of lesions that are listed there, I honestly don't bring my patients to second look ultrasound anymore, right? For stereo with calcs, I don't go for second look ultrasound to find them on ultrasound. For a little bit of non-mass enhancement, I bring them to the MR, because then I know what I'm targeting. And otherwise, I might actually do several biopsies because I'm never entirely sure that I got the right thing. If they become bigger, it's a different thing, right? Any mass over 6 millimeters, focal areas of non-mass enhancement of over 2 centimeters, I will try to find them. But the small ones, sorry, I've given up. MR-guided biopsy is not a difficult thing, right? It's not hocus pocus. It is something that if you can do stereo, you can do a contrast-enhanced mammo biopsy, but you can also do an MR-guided biopsy. It is really quite straightforward. You need more or less the same stuff. You need a compression mechanism. Honestly, for mammography, you have a huge machine that actually compresses the breast. Here you have a very fragile plastic frame that you just push to the breast. It's not that special. I'm always surprised if things don't fall apart, but they work very well. It's mostly a method to immobilize the breast, right? I saw Palak demonstrating this morning that you can lock your coaxial in the grid block. Honestly, personally, I dislike that, right? Because since you don't compress the breast that well, if you bring your needle to the right depth, your lesion will be here, right? So all the time, virtually all the time, you need to be a centimeter deeper and go back, right? If you first lock your coaxial, you can't go a centimeter deeper. So that is the thing that personally makes this a little bit different than stereo. But there are minor tricks that you just learn if you do it quite obviously. Eventually, what is also very important is a great team. Make sure your technicians know what to prepare, what needs to be there, just like they need to know that for stereo, right? And the procedure is more or less, well, it takes a little bit longer because you need to put the patient in and out of the magnet several times, but other than that, the procedure is more or less the same. The nasty thing here is obviously that your direct feedback is not available, right? So you don't have to prove that you were at the right spot by actually making an image of the specimen. What you have is a hematoma in 3D that should be at the spot of the lesion, right? Where you can actually figure out, question yourself whether here we did well because the lesion is maybe a little bit more medial or lateral than where the hematoma is. It turned out to be a fibroadenoma. This was actually just in the right spot, but it's on the edge, right? We should have biopsied a little bit more lateral, to be honest. MR sometimes says that a lesion is unreachable. Honestly, it can't be reached through the holes of the grid. But it's a 3D imaging modality. I'm not sure who of you actually does a thoracic biopsy or a spine biopsy or whatever, right? Taking a needle, screwing it into a lumbar vertebra. If we can do that, honestly, this is soft tissue. You can get these needles everywhere in different angles from the grid. Just make sure that you don't put them up into the thorax. Putting a needle in a lung is not a big thing, but only when it's intentional. All in, if you do MR-guided biopsies, or if you do MR, you need MR-guided biopsy. And to do that, you need to have some sort of a cooperative team that knows how to proceed with these procedures. Just a couple of examples here. Clear lesion in a BRCA1 mutation carrier. You would expect that you can find this on ultrasound, right? So this goes to second look ultrasound, and this was the best correlator we could find for it. It basically came back as a bit of fat necrosis and actually a couple of vessels. We then discussed with the pathologist that could it be hemangioma, and I said, well, possibly it's a small hemangioma. I couldn't really live with that diagnosis, so this is the result. Quite straightforward, this is a hemangioma. We just biopsied loads of vessels, but now I'm sure, right? And can send this patient home in a very confident way. Other classic case, obviously a big cancer, that is still amenable to breast conserving treatment, especially after chemo, but there's a second lesion anterior to it, and that sort of made the difference there. Yeah, eventually, nothing on ultrasound. It's very diffuse. We did biopsy something, came back as normal breast tissue. Doesn't really help. So this ended up actually here. Nikita just said contrast-enhanced memo biopsy is still 2D modality, but you can do that in 3D as well. This is contrast-enhanced breast CT, and doing the biopsy there actually is exactly the same as a contrast or an MR-guided breast biopsy or stereo for that matter, right? It's all iterations on the same sort of technique. And here you can see in 3D where you've been, and obviously also for me, my capacity to actually perform a breast MR-guided biopsy is limited. I sometimes need to wait 2 weeks. I have this machine and it's free every day because I only use it for research. So I see this lesion in the afternoon or in the morning, and in the afternoon we do the biopsy. That's kind of useful. There's also the advantage, I think, of contrast-enhanced mammo biopsy. The machine can only image breasts, right? So it's much easier to actually get access to it. I'm always shocked by the amount of damage that we do with these kind of biopsies, right? If you look at these images, you suddenly see the huge amounts of air bubbles that we introduce and the large hematomas that you don't see on the MR and that you don't see on the stereo. The procedure is the same, so it also happens in these other modalities, just that you now actually get to see it. Nice thing is that you can also show the clips here that tend to float on the blood, so they're in the top of the biopsy cavity. Then we have the high-risk findings, and as was discussed in the previous lecture, these are slowly drifting in the direction of vacuum excision / VAB, whatever you want to call it, and no longer surgical excision. Why? Because they're actually regarded as benign. The only thing that happens is that the patient gets screened. We should also realize that most of these lesions, with the exception of some papillomas and large radial scars, are incidental findings. Right? There were a couple of calcifications, or there was a small fibroadenoma in the breast. You put a needle in and it came back as ADH. Well, ADH is defined by the pathologist as less than 2 millimeters of DCAS. It's really low-grade DCAS, but very small. That means that it's something that you cannot see on any imaging modality, right? That's sort of the definition of ADH, and LCIS is even worse. So what you find is an accidental finding, and what you want is to be confident that there's not more. So for flat epithelial atypia, for lobular neoplasia, right? You get to these kind of consensus meetings and say, okay, if you find it on FAP, we sort of believe you. For ADH, it's always a sort of a massive discussion, mostly between surgeons and radiologists, right? Whether we can actually, or we really need to get more tissue. The likelihood of upstaging is quite big, right? As soon as you find 3 rather than 4 or 2 millimeters of DCAS, it's suddenly called DCAS, and then it becomes cancer. So it's not strange that in ADH you have a much higher upgrade rate. Major thing is, can we sort of ensure that there's not a lot going on? And that's basically, in a lesion like this, vacuum will do, right? In a lesion like this, well, I guess you also have it with vacuum, but you never are completely sure. And that's where we discussed quite extensively in sort of a small expert group where Palak also was member of. And we then came up with eventually the term extended vacuum-assisted biopsy due to the simple fact that all we want is a reliable histological diagnosis. Something where we believe that it is safe to actually group that patient under the group of patients with accidental findings where only follow-up/screening as a high-risk patient is acceptable. This is where Europe has moved now, right? The USOMA guideline is quite straightforward. It says basically this is the thing to do, and if you find much more atypia, then you might still do surgical excision, but otherwise not. That is a change, but this has been a gradual change over the past 10 years or so. I think that as such, this will also in the rest of the world gradually increase. One of the major things here is cost, right? We always say our biopsy techniques are cheaper. I was discussing with a radiologist from Egypt, and she said, well, the needle you use for FAP is actually twice the price I actually charge for the entire operation procedure. And then it's quite straightforward. FAP will never go and make it, right? Then surgery actually is the thing to do, because otherwise we are increasing medical costs dramatically. So it's always a relative thing too. Eventually, breast lesion removal, just excellently discussed, right? It is these kind of diagnostic situations where vacuum-assisted biopsy or vacuum-assisted excision of a lesion is really useful. Very often here, if you just do a biopsy, you shoot one needle through the cyst, and then your lesion is gone. Right, here you bring a needle under, you just stick it in, and you have your diagnosis because the lesion will be in the samples that you have. Fibroadenoma removal is very nice, very effective, but indeed we are also trying to do these kind of things. Patient with a small irregular spiculated mass, quite clearly a centimeter on the ultrasound. In these patients, I also make an MR, right? I will. Honestly, you would say with a memo like this and an ultrasound like that, who would make an MR? Well, I do, because I want to take it out with a vacuum needle. And if I intend to do that, I want to be sure that there's not a large extent of DCAS around the lesion. Otherwise, I might actually do her a disservice. If this is a unifocal lesion, we try to take them out, and then you get this, a big hematoma, and actually quite a substantial one, right? This is a 7G needle, 25 cores. We are talking about half a lumpectomy here. But it does work. You get nice hematomas that you can localize afterwards. And this is done in roughly 40 minutes in the ultrasound room under clean circumstances, right? We don't even use sterile gloves. Overall, radiological interventions might be the lumpectomy of the future, but they are mostly diagnostic procedures, right? The therapeutic ones need oncological endpoints, and therefore we will be studying that for the 10 years to come or so. We need a long-term perspective to see that happening. But for a subset of the patients, this will be the future. And honestly, I have some patients that are old and they want to get rid of tamoxifen and are not being eligible to surgery anymore, where I just do it, right? That will really works and it's fast and easy. That's it. Thanks.
Thank you very much. He has succinctly put together everything that we've been hearing for the last 2 talks. And I think I do agree with you that we get a good histological diagnosis is our purpose for a biopsy. And I think VAB has just increased the tissue that we are picking up, so more tissue for getting a better diagnosis and receptors. As far as excisions are concerned, I think we still all agree it's mostly for the B3 benign lesions. For something that's malignant, I think you have to have a selected patient Because if that patient is unfit for a surgery or has other concerns, I think then we're looking at very small lesions being even attempted at, but a strict follow-up. I think only a radiologist can say a beautiful hematoma. For surgeons, there is nothing called a beautiful hematoma. There should be no hematoma. So I think there we stop with BAB and VAE, and we move on to the cryoablative procedures. So Dr. Rupa Ranganathan, she is the lead consultant and breast and women's imaging interventions and director, breast center at Kawai Medical Center in a hospital, Coimbatore. She has been the course director for FNB since 2019 and the joint secretary of Breast Imaging Society India. So let's hear Rupa on cryoablations.
Thank you. The next, Palak had given me to finish in 10 to 12 minutes. So in that, we will see a little bit about what is cryoablation and how does it work, what is the indication, and what's the procedure, how do you work up, what is the basic technique, and how do you follow up post cryoablation. And we will also look into the guidelines, trials, and the pilot studies. And most importantly, we will see what is the scope of cryoablation in India. So it is another, like a vacuum-assisted excision, it is another minimally invasive percutaneous ablative procedure for breast lesions, which are approved both for benign and not certainly approved for malignant. And it has already come up in the guidelines that it is an accepted procedure for excision of fibroadenoma as an alternative to surgery. And it is now under consideration as an alternative to surgery for a select subset of breast cancer patients. So cryoablation is based on the principle that it kills the target tissue with extreme cold using a cryogen. The cryogen is usually an organ gas or a liquid nitrogen. So liquid nitrogen is much more easier. It's because it's inexpensive, it's easy to obtain and store, it's a single probe technique, and the nitrogen circulates at the distal end, which is non-insulated, and that's how it ablates the tissue of interest. Whereas the organ gas is relatively expensive, it needs a large container for storage. Sometimes a select type of equipment needs helium for active thawing, and it is based on the principle of Joule-Thomson effect, and the rapid decompression of this high pressure gas at the needle tip is used as a principle for cryoablation there. The advantage, it is like any other percutaneous procedure. It is an office procedure done under local anesthesia, and hence we have a faster recovery. And we will talk about this. We already heard from surgeon that there is no risk of surgery and anesthesia because they all do, if it is a high risk for anesthesia, surgery can be done under local anesthesia. However, it has got a better cosmesis and minimal scar. Even with a good oncoplastic surgeon, this cannot be called as a great advantage. The mechanism of action, it has both direct and indirect effects. It causes both intracellular and extracellular freezing, which results in osmotic injury, and it also causes a vascular injury and apoptosis, which are the indirect mechanisms. So when you freeze, thaw, and freeze, and that is what the cycle of cryoablation is about, you cause a significant osmotic injury because of the gradient that you create between the intracellular and the extracellular component, which also causes a mechanical injury when the cell swells, and in addition to that, there is a delayed vascular injury and apoptosis. But what is more interesting and what is more into the future is the immunogenic response the cryoablation causes to the body, and which is the real scope when it combines with the immunotherapy, which we will be dealing a little later. So when you finish the cryoablation, what really happens is the immediate effect is the cell swells and causes an irreversible damage. In a couple of hours, the apoptosis happens at the peripheral zone, and there is a coagulation necrosis which causes hemorrhage, edema, and inflammation, which happens in the couple of days. And in the couple of weeks, you can see there is a clear demarcation in the periphery because of the fibrin stranding and the capillary ingrowth. So within a month, there is a phagocytosis with new vessels at periphery, and 3 months later, there is a fibrotic scar with an intact endothelial layer. So it is not an instant response. It is an ongoing process that has happened, unlike the other ablative therapy where you ablate the tissue immediately, whereas in cryo, the process is slower, and in a way, this is advantage for the immunogenic response that it creates within the body. So the indications, we all know that it is fibroadenoma is accepted, so I'm not going to talk much about the guideline for fibroadenoma. We will see what are these select indications for treating a carcinoma of breast. So when it comes to indications, there are curative in a select subgroup of patients which are under clinical trials for an early breast cancer, a palliative in a metastatic breast cancer, and you can call them as a relative indication where a surgically unfit or a lady who is not willing to undergo surgery, and most importantly, we'll see which is the recent area of interest is the synergistic effect when it is combined with immunotherapy. So in early breast cancer, the indications are the tumor should be an invasive ductal carcinoma less than 1.5 centimeter with less than 25% of intrarectal component or no extensive DCIS. It should be a low-grade tumor. It should be a ER positive and a HER2 negative tumor. It's unifocal, and it should have a clinically and image node negative axilla. And more importantly, many a times this early breast cancer is done under ultrasound guidance, and hence the tumor has to be well visible on ultrasound. So the other important, the advantage which is not seen in the other ablative therapy is the cryoablation and the immunotherapy. So what happens is the cryoablation, because of the apoptosis, it activates an immune response to kill the tumor cells. And it also stops the release of the checkpoint inhibitors. So these checkpoint proteins are, this may be little above your head for the radiologist, I know. At the level of lymph nodes and tumor site, these T cells have these release these specific proteins which binds with the tumor level and at the lymph node level. So the scope now on immunotherapy is to block these checkpoints. So there are checkpoint inhibitors in immunotherapy which actually continuously activates our system to create an immune response rather than being suppressed by these proteins. So what happens in a cryoablation is because it retains the antigen within our body, it elicits more immunogenic response and it creates a synergistic effect. So when you combine immunotherapy and the cryoablation, it works synergistically and the patient responds better. So, and again, what is called an abscopal effect, where you treat the primary and you can see a response in the metastatic deposit. So these are some advantage in the ablative procedure, like in cryoablation. So what we do not offer a cryoablation when it is a lobular carcinoma, when you have an extensive DCIS, and when the tumor is multicentric, multifocal, or also in a bilateral tumor. So how do you work up? First, you need to have a good estimation of the size of the tumor, because it's been proven in several trials that at the size of 1.5 centimeter is where you get a very good response, and also the pathology of the tumor where it is an ER positive, hormone positive, and a HER2 negative tumor. Tumor size mapping is very important, so we do all the modalities, the mammography, ultrasound, and MRI breast to actually assess the extent of abnormality to make sure that it's unifocal and there is no extensive non-mass enhancement around. So we do a core biopsy to grade and also to rule out an extensive DCIS and to get an IHC. So the technique is, you see a small mass here, which is less than 1.5 centimeter. So you insert the cryoprobe. So the tip of the cryoprobe goes beyond, because there is a point where you have the maximum amount of the temperature that develops. So that has to correspond to the center of the tumor. And what also is very important is to have the good amount of hydrodissection. So when the tumor is closer to the skin, which is less than 1 centimeter, it is considered as a relative contraindication to perform cryoablation. And then when you create an ice ball during a cryoablation, you also continuously try to inject the saline so that we constantly separate the skin from the ice ball. And this is what we do. So this is the way that the ice ball can touch the skin and cause an injury. We do not want it, so we create a hydrodissection so that it separates and the skin is protected from the ice ball to avoid a skin injury. The complications are thermal injury, which is because of the extreme temperature, extremely low temperature, skin and muscle necrosis can happen. And rarely, when you remove the cryoprobe, a major arterial bleed is also reported. Minor complications are edema, swelling, and nodular thickening at the procedure site, hematoma and seroma, ecchymosis, and minor skin freeze burns. Post-ablation follow-up, what we are looking at fat necrosis, means the tumor is completely ablated, and what we are looking at the fat necrosis. And MR is considered as a modality of choice. It's usually done around 3 to 6 month time period. Apart from fat necrosis, what is evident on MR is the lack of enhancement in the ablation zone. Like, not the tumor is actually enhancing, the enhancement that you see should favor a fat necrosis and not the tumor, and it is reported to have a high negative predictive value. You can perform an ultrasound immediately where you can appreciate a hyperechoic margin, which slowly decreases in size over 2 years. So this is the example of a post-ablation follow-up where you can see evidence of fat necrosis across all modalities. So I'll quickly go through the literature evidence. This was the first trial, the phase 2 trial, Z1072 from the in the Annals of Surgical Oncology, where they have excised all the post-cryoablation tissue and has proven that there is a 100% response if the tumor is less than 1 centimeter, and there is a relatively good response when the tumor is around 2 centimeter. And we all know about the ICE3 trial, which has released the interim results, and they had a recurrence of around 2% in their group of patients where they had only ablated. There is no hormone therapy or there is no radiation given. And there is another trial which is still ongoing where the follow-up is through all modalities, and again there is no surgical resection. This is called the FROST trial. And you have n number of pilot studies which says that the tumor size of around 1 to 1.5 centimeter has got a very good response post-cryoablation. This is a very recent article which again talks about that cryoablation of the primary tumor is considered as a good alternative for a surgical surgery in an early breast cancer. And this is a trial in a place where I got trained is from the Kamada Medical Center, where Dr. Fukuma is doing a trial. He does cryoablation of the early breast cancer less than 1.5 centimeter along with a sentinel lymph node excision under local, and all the patients go for the radiation and also on hormone therapy, and the recurrence in his literature is around less than 1%. We need to wait for the final publication. This is for to say that the role of cryoablation in metastatic breast cancer. And this is a very interesting ongoing trial where we combine the cryoablation along with the immune checkpoint for the treatment of breast cancer. Now, the very important, I'll take the last 1 minute. What is the scope of cryoablation in India? So we have seen the indications of fibroadenoma, early breast cancer, metastatic breast cancer, and synergistic effect in patients undergoing immunotherapy. So what do we really stand? Should we consider VAB or cryoablation for fibroadenoma? When it comes to a fibroadenoma, the important clinical concern that it is seen in younger patients, it is the concern is the palpability of the tumor. So if you have to compare VAB and cryoablation, VAB is much cheaper because it also gives instant results. The tumor, which is a concern for that lady, immediately disappears with a small risk of hematoma. A cryoablation, if you consider in terms of economy, the cost that is involved, it is 3 times the cost. And the concern is not instantly addressed. It takes a couple of months for the tumor, the palpability of the tumor to risk. However, there is compared to VAB, there is a little risk for hematoma. So for me, if you ask for fibroadenoma to choose between VAB or cryoablation, for all the obvious reasons, I would go for a vacuum-assisted excision than the cryoablation. So what about the early breast cancer? We have no nationalized screening here. That is a big challenge. And we also have the incidence differs, and we have the incidence of luminal A, which was very, very less. We had a chat with Dr. Ritzi last time. He said the luminal A cancers are detected more during screening, and probably when the tumor grows, the aggressive nature also changes and the luminal A becomes a luminal B, which is a very interesting thought. So that may be the reason we don't see a lot of luminal A tumors here. And whether we really fit into the criteria. So we really don't have a cluster of patients which are the indications, inclusive indications of early breast cancer in our country. So treating an early breast cancer is a big challenge. So what is the scope? Probably a patient who is not surgically unfit, a patient who is not surgically willing, a metastatic cancer with a residual disease, a stable residual disease, and patients who can afford for immunotherapy. Should we have a consideration of cryoablation in this super select group with to have a synergistic effect in our trials? So this is one of the patients that we did who was not willing for surgery, who was not surgically fit. She had a large complex cystic lesion with a small tumor which has been continuously bleeding. So we ablated this solid component, and she currently is completely asymptomatic. Her only concern was a recurrent bleeding, and she used to get a 25 centimeter collection within the complex solid cystic mass. So to conclude, cryoablation may not be the most popular choice in India, in a developing country like India, for excision of fibroadenomas. And as Dr. Vani said, we have good breast surgeons who can perform surgery for a surgically unfit because of the anesthetic results. The surgery can be done under local anesthesia along with the sentinel lymph node biopsy. So promoting this procedure as a minimally invasive procedure done under local anesthesia for these, again, is a big challenge. However, in a developing country, several patients present at a later stage where surgery is not possible. We can give them a symptomatic relief in the small group of these patients, and a stable, metastatic patient with a stable residual disease. So all these patients may be a consideration for us in our country. And most importantly, the cost. The cost have to come down if we have to widely use in our country, because currently the affordability of our patients will not match for a large group of patients who have to spend from their own pocket. So considering all this, only if these challenges are addressed in our country, we would think of considering cryoablation to go a long way as a modality of therapy in our country. Thank you so much.
Thank you very much, Rupa. That was excellent. Of course, as usual, I'm the person who brings in the little bit of controversy. Yes, I think VAB and cryo have a role in benign lesions. I still say the same. For the, as far as the metastatic situation that you're talking about, I think we know, and there's enough evidence that when you handle the metastatic lesion, in a metastatic breast cancer, when you're handling the primary lesion in the breast, there is a possibility of dissemination and growth in the distant sites. So one wouldn't look at surgery here. Using a cryo, I'm not sure, because it really would end up with some more problems of fat necrosis, palpable lesions, confusions. And in an M1 patient, I don't think there's any palliation you're doing by keeping the tumor there and cryoablating it, because these would be large lesions, ulcerating. They're not going to be small ones. Very unusual to get a small one.
Partially treated metastatic cancer is what I'm talking about.
Well,
because it has a role in immunological response of cryo, which is also under exploration, is a thing that we can think of in the future.
Sure. So, I mean, that's something that one can keep in mind, that if you have a immunotherapy being given for a specific, say, a triple negative PD-L1 expressing small lesion, distant sites being addressed, cryo, because you're not handling the tumor per se. But I'm not even sure what the long-term results are, because we don't have that much of follow-up for cryo.
We started like that with Sentinel Marine.
Yes.
We're doing that today, right?
But Sentinel is an auxiliary drainage area. I'm talking about the primary handling. So primary.
Will advance.
Yes, it would. I'm not putting a stop on it. I'm saying we need more end results. I'm sure they will come up with.
Definitely, because even the world needs more promising results on this. But these are some of the clinical trials. These are some of the possibilities that we could consider in our country.
So it doesn't have a no role, it has some role, and I'm sure it will, with more evidence coming in, we will have applications, we will find the use for minimally invasive techniques even in breast. So I think that definitely holds. Yes.
So I just wanted to know your cystic lesion, what was the core biopsy diagnosis, or there was no diagnosis in that?
There was a diagnosis. That was an invasive cancer.
Because
it's a papillary.
So that's the point. Papillary carcinomas, which are extremely cystic, they're generally very good prognosis. They're like DCIS.
Yeah.
But what if there's something more ominous and they are prone to error in sampling? So what if it was more than that? So I was just saying, should we not...
This was actually this is a case which we showed that nothing could be offered for her. She was Parkinsonism, stroke, totally bedridden. The entire family, she was 80 years old. The entire family is not willing for a surgical procedure, but she was suffering because of the bleeding. So it is with the palliative intent here to give a better quality of life is
Why
what
not
that
just
procedure.
leave it alone and drain it off?
No, I
We
think what
have been
she's-
doing it 3 times. It's
Rupa
been
has
bleeding
actually-
again and again.
She's given the answer. This is situation where nothing else was possible for the patient,
Yes.
so she's offered it. So obviously, you're selecting the patient is
Yes,
where we're highlighting.
yes.
And this is not like a routine thing that you offer to a patient who's walked into you where you're looking at a complete curative intent.
Yes.
So these are different situations. I think these are
These
going
are
to be individuals'
some
one-offs.
possibilities that for these select, that's why I started my slide with a very select group of patients.
Absolutely.
Instead of giving them nothing, we could offer them a better quality of life. These small subgroup of patients.
Agree
Yeah.
with you completely.
Yeah,
Thank you very
thank
much.
you.
We have Tanuja now with the next talk. I think she's going to talk to us about the B3 lesions. I think there was a huge debate, B3 being B3 or not, or whether they're actually B2s and B4As. So I guess we are still sitting on that B3 being. So let's see what Tanuja has to say about the B3 lesions. This is the rat path, I guess. Thank you. Yeah.
So,
you have a question? Wait, Tanuja.
Not a
Just
question. I know that for breast, cryo is under experimental modality, but it has been proved for RCC and other organs. So what I was suggesting in trial setting, can't we have a trial where we can just have a proof of concept where you do the cryo and do your routine surgery after that and see how much necrosis we have got. I mean, that is how RFA got established, and we now know that up to 3 centimeter we have got around 93% necrosis. So that is why people have done such proof of concept studies. So
Yes.
is there a scope for that? And that is one. Another question is whether because it has got some potential to immunosensitize the tumor, so can it go as in complement to the immunotherapy?
see, both of these are very important points that you brought out. The first I would like to address that you can't compare this to RFA because we are talking about a primary organ where margins are very important and getting a negative margin and having no tumor remaining in the breast tissue is very important. Obviously, doing a cryo, doing a biopsy, doing a study, getting the margins, getting the residual tumor, viability of tumor, all that can be assessed and we can have data on that. But will you be able to prove that in every patient that you're doing, you're going to get the same 100% response? That's one. The second thing is RFA in liver is a different, it's a different method. It has come and seeded there. You have not really got tissue that tumor that's growing there that you're treating with RFA. You may be, with small lesions, you may be. I'm not disagreeing. But in breast, getting the negative margin is something that we have proven beyond discussion that we have to get a negative margin. And that's one of the important points. Yes, Shalaka wants to say something.
So one thing, ma'am, definitely is experimental and may not yet replace curative treatment yet. But one area where I think we could use cryo more often is we see a lot of elderly patients who are not fit for surgery and they
That I
have
think
small tumors. So we see once in a while patients who are very high risk for surgery. That day I had somebody whose ejection fraction was 15%, or somebody who so you can of course take the tumor out under local anesthesia because if they are small, but that is an area where we could experiment with cryo to begin with and follow them up over a time and see how they are doing. Because the primary endocrine therapy alone is also considered equally acceptable in these patients who have other competing causes of mortality, morbidity because of their comorbid factors. So this is to begin with, that is an area where we could actually try cryo, maybe.
Absolutely. And I think no surgery is also an area that one has considered, especially when you put them on systemic therapy, which it is very sensitive to. Cryo can always be attempted and you can get all the data, but then finally you need to see how you're going to clinically apply it in fit patients, which is where I think there will still be a limitation. As far as the unfit patients, the indication still exists. You can do it even today, even without that evidence. But yes, one would definitely want to know what is the kind of residual disease and what is it that you're leaving behind or not leaving behind. That kind of a study is always doable and feasible, and I'm sure Shalaka will help you out in being the co-investigator there since I'm out of the air right now.
No, see, as
So
we
this should be possible, definitely
as
possible.
We promote organ preservation in almost all the organs.
Yes.
So even with BCT, we expect that radiation will take care of any other, if at all there are any multicentric disease or microscopic disease, and we depend on radiation that it will take care of that. So similarly, this can be a potential modality which I think we need to explore, because again another advantage of cryo is that it can be done under local anesthesia. It will not need general anesthesia.
True, very true. So I'm sure selected patients, if you have defined the inclusion criteria, we can definitely have a study like that. So there are a lot of limitations. I mean, that you've very appropriately said, because you are still leaving behind something. You may have taken out cancer, but there is something. The patient will feel it, and it doesn't just disappear, because there will be a tissue reaction, and the tissue reaction will cause scarring, will cause fat necrosis, any of those. So those will remain, and you will perpetually be following up, and when there is a dilemma, there will be repeated biopsies, there will be a lot of other invasive procedures and follow-up. You're not going to stop at one procedure and say, okay, I've done my bit and the patient is fine and she can go home. Because the sequelae is what we are worried about. And the fact that you may not really have ablated completely. And are you going to then say that you're going to do cryoablation and do radiation for rest of the breast? Is that what we are attempting? So there is no evidence as to what is the next step. So till that becomes clear, I think we still have to keep it as an experimental procedure. Possible in some unfit patients, yes. Fibroadenomas, no debate. You can go ahead and do cryoablation, small ones. Cryoablations, you can do VABs, you can do VAEs, do whatever. But the point is that in a cancer, I would still have my reservations. So I think that remains in spite of all this.
So I think we'll cancel the talk on B3, and because this is a B3 lesion, right? So we can do that. I'm absolutely okay with it.
I have some
This is very important to tell us it is a P3 lesion, so you have to tell us.
I have a small comment to make, Dr. Vani here. SBRT is a accepted treatment in carefully selected patient with the treatment with curative intent, hepatocellular carcinoma, lung cancer, and sometimes kidney cancer. There also you do it with the therapeutic and curative intent, and then you don't know about the margins. So why can't we use cryoablation in selected patients?
We can. I'm not saying we cannot.
Yeah.
I said we have to have long-term results. You have to know the sequence.
Yeah, that's exactly. I agree with you. The SBRT established treatment because we have long-term data for that.
Sure.
So in future, cryoablation may also have similar type of scope.
Yes, absolutely. I mean, I don't disagree there. I'm saying we need to run a study. And that, the only way you can do a long-term is you do a routine procedure versus cryo. And that kind of randomized may not happen, but you will have some patients that you can do and do a pilot study, follow them up. But by the time you get those results, I'm sure people who are offering cryo would be offering a lot more patients even without the evidence, because it has started being done. So there is that little, you have to put a little bit of rider on that, saying that, yeah, this is an experimental procedure, have a follow-up and see. But it will end up with super selection. Tanuja, I think we will go on with the next talk. It will be of time being restrained, yes.
So anyway, I thank the organizers of the BRIT conference for giving me this opportunity to talk on pathology of B3 lesions. So essentially, I think for those of us who are on the other side of 50, we understand the words like gray and borderline. So essentially what B3 means borderline. But trust the British to sugarcoat it into a system that talks about it as a B3 lesion. So essentially what B3 means is these are lesions that are of uncertain malignant potential. So these are lesions that are extremely heterogeneous, and this is a context especially reserved for core needle biopsies. You cannot use, if I call an excision specimen as V3, you will have another discussion, and that will be a thing. So it's especially given for core needle biopsies and in regions that are heterogeneous, so that you tell the surgeon or the clinician that this needs more attention than maybe a B1 or a B2 lesion. So this is the reason that there is a B3, that we are doing core sampling and we might miss the boat, and hence it's very critical to report atypia in any biopsy that qualifies as B3, because that will tell you what to do next. So this is a report from the UK NHS, and you can see that this is a pathology audit. They have around 7.9% of B3 lesions, and you can see that with atypia, the incidence of malignancy is 1.6, and without is 1, so not much of difference there, but it's very critical to report whether you have atypia on that. Now I can see some postgraduates and in the audience, so for that, to make pathology simple for you, please understand the single unit in the breast is a acinus, which is composed of the luminal cell and a myoepithelial cell. That myoepithelial cell has a cell and the lamina that it produces. Now, what we do is we use two stains. One is cytokeratins. We use different cytokeratins for the luminal, which are 818, and for the myoepithelial cells, we use 5-6. Why do we use it? Because if I have an epithelial proliferation and I see an admixture of both type of cytokeratins, it tells me that this is a benign lesion. Whereas if only one cytokeratin predominates, we call it clonal, and that means this is something ominous. Now we use this liberally in a core biopsy. We use stains for myoepithelial. There is one stain that coats the basal lamina as well as the cell, that is smooth muscle heavy chain complex. So you see a basal lamina at the bottom of every acinus or duct, whereas in the nucleus stain is P63, and P63 has a disadvantage that it only stays the nucleus. So between the gaps, if a cell is coming out in a DCIs with invasion, P63 may not help us, but the SMHC helps us, and that's why we have two stains there. Now, what are the lesions that constitute B3? Clearly, the intraluminal type of proliferations, the mass-forming lesions which are actually benign, but they have atypia, papillary lesions, and fibroepithelial regions. Now, a simple diagram to understand what all is happening here. So the same acinus, now if it gets irritated, any intraluminal irritation, which may be a physiological, whatever, the first cell to start proliferating is a myoepithelial cell. So it proliferates and it produces a very haphazard kind of a proliferation, and that we call as usual ductal hyperplasia. Now imagine any hyperplasia is a soil for mutations. So imagine the luminal cells now undergo mutations and they push back the myoepithelial cells, which are represented in green, and they now form a complex which is purely clonal of luminal cells. That is omnious because now the luminal cells are taken over. We call it atypical ductal hyperplasia. Please understand, atypical ductal hyperplasia is actually early DCIs. So it's already DCIs because it shares the molecular event of low-grade DCIs, and we separate it from DCIs based on a quantitative basis, and I'll tell you about in some while. Now, if you put more mutations in this, that cancer becomes frank. This is already low DCIs, but if you have the chromosome 17 pathway HER2 expression, that gives the tumor the potential to invade the adjacent, break the basal lamina and invade, and this is where my myoepithelial markers will help me. So why do intraductal proliferations or intraluminal proliferations call as B3? Because please understand they are spectrum of proliferative disease. So you may have ADH, but it may be part of a larger disease which includes DCI. So unless I sample this more, I wouldn't know. The difference between ADH and DCIs, for example, in a biopsy, I got one duct with ADH. Now, in the rest of the specimen, you may have 3 ducts with ADH, which automatically makes it DCIs, because the difference between ADH and DCIs is quantitative. So, less than 3 ducts is called as ADH, and more than 2 ducts is called as ADH, and 3 or more is called as DCIs. So, the same thing. Even the risk prediction of an ADH is equivalent to DCI, so please understand that they're very similar kind of lesions. It's good to repeat a wider core needle biopsy because that might help solve some of these lesions. An example is, this is a lesion. Remember, in India, we don't have much of screen-detected lesions, so this is one of the palpable masses. I get DCIs. Now, this is not really DCIs because you can see it's everywhere, and it has this collar of fibrosis that whenever something is breaking out of the drug, the first thing that happens is a fibrosis to wall off that invasion, and that fibrosis is an indication that something is going on here. I do my myoepithelial markers. This is the smooth muscle heavy chain complex. It is missing at places, but I don't see any nest outside. I am worried about this DCIs, but I can't call it invasive. It's a 7 centimeter mass. It is excised up front. I called it DCIs, and we need additional material. And what you see is a frank invasion in the excision biopsy. So moral of the story is, when you have a palpable DCIs and there is no report of invasion, don't give you have to go for upfront aspiration or repeat biopsy to pick up that infection. What about the lobular spectrum? Now this is a normal breast. You have the luminal cells, you have the myoepithelial cells. Now this undergoes involutionary change. What is the involutionary changes? It is no longer such prompt and juicy, it just gives up its function. It becomes dilated, and that's fibrocystic change. Now instead of dying, if it decides to fight back and undergo more mutations, we have a very unique morphology, and that we call as columnar cell alteration. If it decides to just multiply without, actually doing anything, we call it sclerosing adenosis. This is a mass-forming sclerosing adenosis. And radial scar is another story that we'll talk about a little later. So let's address the columnar cell continuum, because that's the common pathology that comes under mammographic visualization. Why? Because the cell changes its phenotype. Instead of being the non-active cell, it becomes an apocrine cell, and cell with apocrine snout, and starts secreting a lot of fluid which gets calcified, and that's why it's one of the commonest pathology that you see in mammographic excision. If you leave anything like that, it undergoes hyperplasia. So you see hyperplasia, and the next step is atypia. And this is the most ominous. So the flat epithelial atypia, mind out, all these changes are happening in the lobules. So flat epithelial atypia is the equivalent of ADH on the ducts. And so this is to be taken like low-grade DCIS or an equivalent. So this, if it's extensive, automatically becomes low-grade DCIS. So the problem is that people in India use different diagnostic patterns, and same abroad. And this is a JAMA study which said that depending on how the core biopsy wording was, the patient's choices vary. So if you call flat epithelial atypia, there's no carcinoma word in it. So patient is happy, does not want an excision. Whereas if you call suspicious for DCIS, patient promptly got an excision. So mind you, the lesion is the same, but the interpretation and the message sent across will differ upon the terminology used. So what we do is we try to look for markers which will help me be sure. And the markers we do is, remember, a strong expression of ER, BCL2, cyclin D1 is usually indication that this cell is not normal. In a normal cell, there is heterogeneous ER expression. So then you call it DCIS. And if it's obviously high grade and it is expressing HER2, it's clearly a DCIS. Let's look quickly through the mimics of mass-forming lesions. I'll only go through radial scar because that's commonly seen radiologically. Now this is a 50-year-old radio. Mind you, all these complex sclerosing lesions have atypia. So I remember this case that this lady came in, the FNAC was carcinoma. She came from a big hospital in Mumbai. And Garvit was here, and he said, just call it carcinoma and FNAC, tomorrow we're taking her for surgery. I said, no, something is wrong about this. I'll say atypical cells, suspicious, you get me a tissue tomorrow before surgery. And it was a radial scar. Now why? Because it is mass forming. It shows you the atypia that you get, and it shows you tubules. The clue is the presence of these myoepithelial cells, which we demonstrated subsequently. So why these lesions are dangerous? Because they show you infiltrating epithelial cells, they are mass forming. Only clue to the diagnosis that they lack mitosis and necrosis. So for pathologists, these are not common lesions, but this is one of the commonest mistakes on pathology. Now radial scar, this is the whole lesion. Now it's like the khichdi that we make in dal khichdi, with everything we put in one pot, and that's what it turns out. So that's exactly what this is. It's a mixture of different lesions. You see, if my core biopsy goes here, sometimes people call me, the core biopsy was fibrocystic change. Suddenly how it became a radial scar? It became a radial scar because your core went through a different lesion. So if it goes through here, you'll call it sclerosing adenosis. If it goes through here, you'll call it a papilloma. If it goes through here, you will call it a fibrocystic change. And sometimes, if it goes through here, there are these complex tubules which mimic cancer. Somebody might even call it malignant. Now, that's about the thing. I'm sorry I have to hurry through some of the lesions, because now we know papillary lesions are a nightmare for everybody. And we know that in a core biopsy, if you see papillary lesions, that there's always 10 to 20% chance of an upgrade in further. Now, what is so notorious about this papillary lesion? It's very clear that if I have a papillary lesion, and if my needle goes through the periphery, the core biopsy, I will call it non-diagnostic, and sometimes the surgeon says, it was very much within the lesion, the radiologist says, but this is one of the common problem. The second problem is that the myoepithelial cells proliferate and they produce all kinds of weird patterns. And if your needle goes through one of such atypical proliferation, you might also get a diagnosis of carcinoma.
lastly, encapsulated papillary carcinoma is a unique entity. That's why I was asking Rupa about that case, because that's exactly what it would look like. It will look like a cyst with a mass lying under it. Now, individually, this is cancer because it lacks myoepithelial cells and it has all the fine markers of a cancer. If my needle only picks up this without picking up the cystic nature of the lesion, I will call it invasive carcinoma, and that's the problem with this. And most papillomas tend to have DCIs or invasive in the adjacent breast. So if I do a core of papilloma and observe that patient, this lesion may prop up later on, and that's the reason papillary tumors are a nightmare on private. So again, the second problem is, besides this heterogeneity of sampling, there is a problem about how to call something as ADH or DCIs within a papilloma on core biopsy, and that's the reason which it becomes a, I will not discuss this, is more for pathologists. So this is a web of a papilloma. You see it has a single point of attachment, and the rest of the fragments are floating like that in the blood. And this is a very compact mass. I don't even do stains on such ones. Here is a mass which was not detected as papillary, and I know this is a papillary tumor. It's very compact and it has lots of epithelial cells. Now I start worrying. I was not worrying because there's a lot of epithelial cells. I do my markers for myoepithelial cells. I see a nice basal lamina, so no invasive, but lot of cells here are only of one type, and I can see the 818 is predominantly, the 5-6 is not there. So I'm worried that this is a clonal population. So I don't call it DCIs, but I say this is a complex papilloma with atypical ductal hyperplasia. The excision of that case was also the same, so that was good. Now here is another case. Now this, in contrast to the previous one, I have multiple points of attachment. I don't like this when I see this in a papilloma. When I look at the myoepithelial cells, there is, the CK56 is again very minimal, but the ER is heterogeneous. Remember what I told you, that the ER should be strong if something is DCIs or malignant. So I was dwaddling, so I called it papilloma with ADH. And in the final excision, that papilloma was not the worry at all. The whole part of the lesion was something in situ, and this was actually a lobular carcinoma in situ. This is the E-cadherin stain in that. I went back to the core biopsy and I did E-cadherin of that. In the wall of that papilloma, you could see the cells which are E-cadherin negative. Lobular carcinoma is E-cadherin negative. So this is what is the problem with papillomas, that it is part of a huger, larger khichdi. And this is just to tell you that when you have a papilloma with ADH, this is our own data, the chances of getting invasive or a DCIS next to it is extremely high. Now quickly about Phyllodes tumor. Phyllodes is also a very heterogeneous tumor. So if you sample one area, you might call it fibroadenoma. If you sample another area, you might call it Phyllodes tumor. So here is, and same thing happens with grading of a Phyllodes tumor. So here is what we look for in Phyllodes tumor, to put it very simply, is lots of stroma, very little epithelium. That's how we make the diagnosis. So when you see as a, I'm sure as radiologists understand, that's the stroma, and that's your epithelium. In this all course, what hits you is the stroma. So I'm worried about this. I go on the higher part and I see that lot of atypia, that means rotten juicy nuclei and an occasional mitosis. So it's very easy, this is a Phyllodes tumor, and I call it Phyllodes tumor, but on excision, it was a very high grade malignant Phyllodes tumor. So moral of the story is that even one area of malignancy makes it malignant Phyllodes, and that your needle might not pass through it. Now, sometimes discussion helps in sorting some of this lesion, and here is a case. This was a 27-year-old girl, and you see lots of stroma, right? And very little epithelium. So my diagnosis was very clear, Phyllodes tumor. But then Purvi called me, and she told me, madam, but where is the mass? There is no mass. So then, where is that the Phyllodes tumor? Actually, this was a fibromatosis. So moral of the story, a B3 became B2, just by discussion. So sometimes talking to each other helps, and that's just one of the cases in my repertoire. So to conclude, the spectrum of B3 lesions essentially represents tumors that are heterogeneous, and hence there's a high chance of upgrade on core biopsy. This includes all the lesions that I've told you. And what I feel today is, after looking at some of the cases in our archives, that B3 requires discussion, and sometimes just a repeat biopsies or a broader core of the biopsy helps in lowering down the rates of this B3. Thank you so much. I'm sorry I had to run through some of the things because the time was short.
Thank you very much. I think Tanuja has highlighted one very important thing. Whatever it is, treating a breast cancer patient is a teamwork. The clinician may suspect, the radiologist will give us a diagnosis, but finally it's the magician who tells us what is happening and what is the diagnosis.
So the
I think
pathologist is the magician here then?
Yes, pathologist is the one who solves the problem for us. So clinical RAD-PATH, I think it's all three, it's never one alone. And all three working together as a team is where we solve the problem. So thank you very much.
Yeah, I think I am very privileged that I'm Tata Hospital because I have fantastic colleagues, both on the surgery side, the medical oncologist, and the radiology side. They'll kill me now, the radiologist. So the radiologist side, that, so many things we learn every day, and thank you for that. Thank you for the opportunity. I was going to put a case of a papilloma, which Palak had in her mind that this is not a papilloma, this is malignant. She chased the patient for 6 months, and when the biopsy came in, it was an invasive carcinoma. I was trying to find that number, she'll give me later, and I'll put it in some other meeting. So this is where I think discussions help.
So thanks, Tanuja, for such a nice insight, because we always think as radiologists that whenever we put a needle inside and document that it is inside lesion, we have done our job. But maybe there might be sampling errors, and core biopsy may not give the right representative sample. So in that scenario, do you think that the vacuum-assisted biopsy will give you, as you suggested? Yeah, of course, surgeon. After the surgeon, surgeon always. But after the surgeon, do you think that vacuum-assisted biopsy will give you adequate material or the broader course as you suggested?
So our rates of B3 is lower on VAB because obviously you are happy that you have got more cores there. So that's definitely there. But papillary lesions, I won't want to do any VAB because they are better excised in toto because we need to study the wall of the lesion. And that's the reason I'm very averse to, but maybe in years down the line, something will come in and you can excise the cavity without destroying it through the VAB, without piecemeal fragmenting it. If you can excise the cavity through just like a laparoscopic people do, then fair enough, but the wall is very important in a papillary lesion. So not for a papillary lesion, but for everything else, VAB is fantastic.
And initially as we started doing VAB, the feedback from the pathology was that we are getting crushed samples. So is there anything that we can do about that, or how do
So
you?
what we have started doing is a little bit, this is a story of another day, but I think I'll stress it. So what happens is when you transfer biopsies from a radiology, so what we do is we dump, right? That's the practice. We dumped in a formalin bottle, then it goes. So now we started filtering the biopsy. So instead of, so you use a forceps or something, and we also use, and we kind of mash them. So we don't do that. We just filter them in a core and transfer them. The filter paper is processed so that you're not battering the tissues too much, and that really helps. So little bit of understanding, I was just talking to you that core biopsies from any sites have to be handled with care. So we're trying to figure out ways and means of making sure that the core is the way that it came from radiology. It does not get distorted by, when we put it in processing, we take out the core, we put it in a tissue, and then the processor does all the job. So that transfer also takes a little bit of a headache.
Well, thank you very much.